I'd like to welcome our participants that have joined us today for our webinar titled An Update on Stewardship Measurement Hospitals, Programs, and Antibiotic Use. This presentation is being given by Captain Arjun Srinivasan from the Centers for Disease Control and Prevention. So we're very fortunate to have him with us here today. I want to remind our participants that have joined us that this is part of our Journal Club series, and at a later time or anytime during the webinar, you can go to our CIDRAP website, and on the right-hand corner, there's a Journal Club content component that you can click on, and we actually have the article and slides there available for you under today's webinar. As I just wanted to continue on introducing Dr. Srinivasan, our speaker today. He is the Associate Director for Healthcare Associated Infection Prevention Programs in the Division of Healthcare Quality Promotion at the CDC. CDC's National Center for Emerging Zoonotic Infectious Diseases. As an infectious diseases physician, Dr. Srinivasan oversees several CDC programs aimed at eliminating healthcare-associated infections and improving antibiotic use. For much of his career at the CDC, Dr. Srinivasan ran the Healthcare Outbreak Investigation Unit, helping hospitals and other healthcare facilities track bacteria and stop them from infecting other patients. Today, he leads the CDC's work to improve antibiotic prescribing and works with a team of CDC experts researching new strategies to eliminate healthcare-associated infections. And just a few more instructions before we start, just to let the participants know, we really encourage your engagement and your questions to Dr. Srinivasan today, and you're able to submit those at the lower right-hand corner of your screen in the chat box. Please send those to all panelists, and we'll be able to address those at the end of our webinar. Your lines will be muted, so this is your way to engage and connect through this chat box. And this webinar is also being recorded, and as a part of the Antimicrobial Stewardship Project at the Center for Infectious Disease Research and Policy at the University of Minnesota, we will be hosting and not only hosting this webinar, but posting it as a recording on our YouTube channel after the webinar. So with that, I'd just like to thank Dr. Srinivasan for joining us today. We look forward to your presentation.
Hi, Marty. Thank you so much. And thank you to all of you who have joined us today for this webinar. I'm going to provide a brief update both on our measurement of the implementation of antibiotic stewardship programs in acute care hospitals in the United States, and also a little bit on where we stand with our efforts to measure antibiotic use through the CDC's National Healthcare Safety Network Antibiotic Use Option. I don't have any financial disclosures relevant to this talk. Most of you know that every year we do administer through the National Healthcare Safety Network a survey of all the facilities that report data into NHSN, including all of the 4,000 plus hospitals that report data into NHSN. And every facility that wants to report into NHSN must complete this annual facility survey data. And because of the CMS mandates and many state requirements, essentially every acute care hospital in the United States is now reporting data into NHSN, more than 4,000 acute care hospitals. And so this survey is completed every year by about 4,000 acute care hospitals. And it's completed in the first quarter of every year to reflect activities that the hospital would have been conducting in the previous calendar year. So for example, we just sent out, or in the process of sending out, the survey to ask about practices in 2017. So the survey administered in 2018 covers practices in 2017. And we added questions about the implementation of antibiotic stewardship programs, about specifically the implementation of the CDC core elements for hospital antibiotic stewardship programs to the survey in 2014. So we now have 3 years worth of data, 2014, 15, and 16, on implementation of the core elements in U.S. hospitals. And many of you saw the journal article that we're kind of talking about today, which was, of course, the publication of the survey results. Now, what you saw published were the 2015 survey results, but what I'm going to share with you are actually the 2016 results. We recently completed the analysis of the 2016 results, and these data will be going up onto the CDC website on our Patient Safety Atlas. If you search for the CDC Patient Safety Atlas, very shortly these 2016 survey data will be up. So we had published the 2014 and 15 data, and now we're probably going to be putting this data up onto the website so that people can access it very quickly. You can see in 2016, 64% of hospitals, so roughly 3,000 of the some 4,700 hospitals who responded to the survey, reported uptake of all 7 core elements. And you can see that implementation of each individual element is really quite high, over 80% for each individual one. But when you look at the aggregate, how many places have all of those elements in place, that stands at 64% in 2018. You can see that the ones where we do lag a little bit are leadership, some of the tracking, and also the educational areas. So those, I think, would be our opportunities for improvement moving forward. There continue to be some pretty significant differences in implementation of the core elements among different types of hospitals. And in particular, you can see that smaller hospitals, less than 50 beds, and the smallest hospitals, the critical access hospitals, which are less than 25 beds, really do lag very far behind the larger hospitals. In fact, that difference is really quite striking. So hospitals less than 50 beds are at 46% that have implemented all of the core elements, versus 82% of hospitals greater than 200 beds. So there's clearly a really important difference between smaller and larger hospitals, which is probably also reflected in this difference, pretty big difference between non-teaching and major teaching hospitals. Of course, the major teaching hospitals do tend to be the larger facilities. If you look at our annual map of the percent of facilities in each state that report meeting all 7 core elements, this has changed very nicely over time, and you can see that in many states, we are now seeing percent implementation take up into the 70s, in some cases the 80s, in Utah, Nevada, almost 90% of the facilities report having all 7 of the CDC core elements. So we're really seeing some encouraging progress that's being made, and some of the states have really made major progress. For example, I'll draw your attention to West Virginia on this map. In the 2014 survey, they actually lagged well behind the national average, and now they're up to 75% of their acute care hospitals having implemented all 7 of the CDC core elements in 2016. They're actually a bit ahead of the national average. So some really encouraging progress in many different states. This graph just summarizes the changes that we've seen over time, and you can see the first time we did this survey in 2014, about 41% of all the acute care hospitals reported that they had all 7 of the core elements in place, and in 2016 that had gone up to 64%. So we are making some, I think, big strides in implementation of the CDC core elements in our acute care hospitals. We have a ways to go. You know, we really want this number to be 100%. In fact, we do have a goal by 2020 to have all hospitals, all acute care hospitals, implement all 7 of the CDC core elements. And I'm encouraged that we are definitely seeing progress in that direction. This just gives you a sense of who is responding to the CDC survey. And I think the areas that I wanted to highlight here are the growth in the responses of critical access hospitals. You can see we've almost doubled the number of critical access hospitals that are reporting information into the NHSN survey. So that's really encouraging, because that means we now have some pretty accurate data on what's going on in critical access hospitals. There are about 1,300 or so critical access hospitals in the United States. You can see that in 2014, we had, around half of those facilities reporting data, and now we're much closer to having 3/4 of all of those hospitals, critical access hospitals, reporting data into NHSN. So that's certainly been encouraging. But one of the questions that people ask, and I think it's a really good question and the right question to ask, is, how accurate are the survey results when it comes to the antibiotic stewardship practices? You know, the NHSN survey goes to the facility administrator for NHSN in every facility where they're using NHSN. So in hospitals, that's, you know, almost always going to be the infection preventionist. So the survey instructs that that members of the stewardship team should be asked for input on the stewardship questions, but we don't know how often that happens. And so the question has come up, well, you know, how good are these results? You know, are the results the same that you would get if you were able to directly poll the stewardship team? Does the infection preventionist really have the most accurate information, and are the stewardship teams being consulted? So to try and get at some of this question, we have been partnering with Vizient to try and see if we can do a little bit of validation of the results of the NHSN survey. So in 2016, Vizient decided to do a survey of their member hospitals. And what they did is, in addition to all of the other questions that they asked, they put the NHSN stewardship survey questions verbatim into their survey. The difference between the Vizient survey and the CDC survey is that the Vizient survey is being sent directly to members of the Vizient stewardship listserv. So their stewardship survey really is going to the person in the hospital who is probably most directly involved with the antibiotic stewardship efforts, because they have gone to the trouble to sign themselves up to be in the Vizient stewardship listserv. So what they did is they were able to share those survey results with us. They got permission from the hospitals to do that, and we were able to match almost 200 of the Vizient hospitals to hospitals that had also completed the NHSN survey. So now we had a cohort of 189 hospitals that had completed identical questions on both the NHSN survey and the Vizient survey. And if you look at the respondents, it's indeed what we suspected. So 83% of the Vizient respondents were pharmacists. Most of the rest were stewardship physicians. And what was interesting is that the Vizient survey, you know, they really were able to get into some details that we can't get in NHSN, and they asked about the type of pharmacist who was completing the survey. And not unsurprisingly, in smaller hospitals, it was likely to be a director of pharmacy that completed the survey. So those might be smaller pharmacies where they maybe the director of pharmacy is the one, you know, maybe the only full-time staff member at the hospital, or at least the primary staff person who completed the survey. And larger hospitals, it was more likely to be a clinical pharmacist. And about half of the respondents to the Vizient survey did specifically ask whether or not this stewardship lead had helped with the NHSN survey, and only about half of them indicated that they had participated in completing the NHSN survey. The bottom line result was, in my opinion, fairly encouraging. The reported implementation of all 7 of these elements in the 189 hospitals where we had data from both surveys was actually pretty close. It was 58.2% in the Vizient survey compared to 54.5%, so 58 versus 55 in the NHSN survey. And we think that has some degree of face validity. We think these results are kind of what we expected. We expected the person who was most familiar with the stewardship program, so right, the stewardship pharmacist, to be most aware of what was going on. And so indeed, this is probably the case. There are a handful of instances where the infection preventionist who completed the survey might not have known about a stewardship activity, while the stewardship pharmacist did indeed. So that percentage implementation was a little bit higher. You can see that across the board, there was really pretty good agreement between the two surveys. And in almost every instance, the Vizient survey response was just a little bit higher. The exceptions being the reporting and education areas, where the Vizient survey response was just a little lower. We surmise there, particularly in the educational arena, that may reflect the fact that the infection preventionist might consider some of the training that they might be doing on Clostridium difficile, multi-drug resistant organisms to be kind of stewardship education, whereas the stewardship pharmacist might have a different take on some of that and might consider those efforts not really to be stewardship education and might be having a slightly different standard for what counts, if you will, as stewardship education. What was interesting in the Vizient survey, so this is results just from the Vizient survey, was looking at implementation where there was a clinical pharmacist completing the survey versus a director of pharmacy completing the survey. And, I think what this most likely reflects is the same thing we see in the NHSN survey, which is the implementation is higher at the larger hospitals. And so I suspect this is, rather than being a marker directly of clinical pharmacists maybe being more familiar with what's going on, and there may be some of that that's embedded in here, but this is also heavily influenced by the fact that the director of pharmacy responses came overwhelmingly from the smaller hospitals, the ones less than 250 beds. Our take-homes from this was that there's generally pretty good agreement, both on the individual core elements and on implementation of all 7 elements between these two surveys. And that was certainly encouraging to us because this has always been a concern of the validity of the NHSN survey. Reported implementation was a little bit higher when the pharmacists were directly involved. And as I said, I think this could reflect more awareness of specific stewardship activities by the pharmacists. And, what was a little discouraging to us was that only half of the Vizient respondents indicated that they had helped with the NHSN survey. Now, it's entirely possible that that number is not quite as bad as we think it is. It's possible that there were other stewardship staff at these hospitals who did have input into the survey. So, for example, most of our respondents were pharmacists. It's possible that the stewardship physician at some of these hospitals was engaged by the infection preventionists to help fill out the survey. But certainly, that 50% number is definitely one that we would like to see much, much higher than that. Ideally, we would like to know that in every hospital, the infection preventionist is engaging the stewardship team in completing the NHSN survey. And as I said, this difference between reported implementation between directors of pharmacy and clinical pharmacists, hard to know exactly from these results whether that reflects more familiarity with the stewardship programs by the clinical pharmacists or simply is a marker of the bed size of these different types of hospitals. Well, what are the next steps for the stewardship survey? I showed you that encouragingly, the percent of hospitals that have reported implementing all 7 of the elements has gotten higher and higher. And we expect that in 2017, that number will be even higher still because, of course, 2017 will be the first year that the survey will reflect the implementation or the requirement by the Joint Commission for hospitals to have stewardship programs. And so we've been talking a lot and thinking about how we can kind of take a next step with the survey. What we really want to be able to do is, once we know that implementation of the core elements is getting quite high, we want to be able to try and use this survey data and try to combine the results of this survey with data on antibiotic use, data on resistance, data on CIDRAP, to really begin to try to understand, well, what are the specific factors that might be associated with more effective stewardship programs? And so one of the things that we've been working on is talking with lots of experts in antibiotic stewardship to say, what would you ask? What do you recommend we ask in order to try and get a deeper understanding of the types of stewardship practices, stewardship policies that might be associated with more effective programs? And so there are a number of areas where I think we've gotten some really good feedback. There are a number of more specific details that people have said they would find very, very helpful. And a big one has been wanting to understand more about the level of both physician and pharmacist effort that's committed to stewardship. So people, for example, really would like to know, well, how many hours per week do people spend on stewardship, both the physician and the pharmacist? And a related but not the same question, how much of that time is supported for stewardship? How many hospitals do we see where their funding support may be very small. Maybe it's zero. They don't even have any direct funding support, and yet they're spending 5, 10, 15, 20 hours a week doing stewardship activities. So there it really is an interest in learning more about the level of both support and commitment and effort for stewardship. People want to know what type of antibiotics are being focused on for interventions, where the stewardship program fits into the hospital reporting structure. Several people have said, it might be interesting to know if programs are maybe more effective if they report directly into the chief medical officer or the CEO versus what does that look like if you report into another committee like the Pharmacy and Therapeutics Committee. And people really want more insight into whether or not someone on the stewardship team did participate in filling out the stewardship questions on the survey. So we've made a number of revisions. All of those things we've talked about, we've incorporated into the survey. So, for example, we're asking about percent effort and number of hours per week doing stewardship. Excuse me, we're asking about where the program fits in the organizational structure. We have added a new question which specifically asks, did someone from the stewardship team participate in completing these stewardship questions? So this revised survey is now has to be approved by the Office of Management and Budget, and we're in the process of seeking those approvals now. We anticipate releasing this new survey, implementing it in 2019 to cover practices starting this calendar year, 2018. So next year, when you see the NHSN survey, you will hopefully see this revised survey in place, and hopefully many of you who I assume are stewardship leads in your hospitals, if you haven't been engaged in filling out the survey, you will be engaged in the future starting next year in filling out the survey. Well, where have we seen the progress in some of these different hospital types? As I mentioned, the one area where we do see a lag in implementation is in our critical access hospitals. Now, I will point out we've seen some really encouraging progress in critical access hospitals. So the percent of critical access hospitals reporting on the survey that have implemented all 7 core elements has more than doubled between 2014 and 2016. So that's great, but their overall percentage is still only 43%. So they definitely lag all of the other hospital types. So this is an area where we have wanted to focus, especially since we know that critical access hospitals are certainly not spared any of the problems of antibiotic resistance and Clostridium difficile. Indeed, we know that most critical access hospitals do encounter cases of both methicillin-resistant Staph aureus, or MRSA, and Clostridium difficile. And what's interesting is that a growing number of them are now encountering some of the infections with the highly resistant gram-negative pathogens, the kinds of things that we would have said, oh, well, these are really would be seen in our larger academic or tertiary care hospitals, and that's definitely not the case. The numbers are still small, but they're growing at a fairly alarming rate. In 2015, 1.7% of all critical access hospitals reported a healthcare-associated infection with one of these highly resistant gram-negative pathogens, things like carbapenem-resistant Enterobacteriaceae, and that number had almost doubled. In 2016, it was 2.9% of the hospitals reporting one of these highly resistant infections. And so they are seeing the same types of challenges with antibiotic use and exposure that our larger hospitals are seeing. And we know that critical access hospitals use antibiotics just about as much as any other hospital type. This is a breakdown of rates of antibiotic use reported by hospitals of different bed size, reported into the CDC's Antibiotic Use Option. And as you can see, there's really no significant difference between the smallest hospitals, critical access hospitals, fewer than 25 beds, and our larger hospitals. And so antibiotic use is about the same in any type of bedside hospital that you go to. So it's not like antibiotics are not being used at critical access hospitals. At the same time, we know that critical access hospitals have lagged in their implementation of antibiotic stewardship, And if you talk to critical access hospitals, to people who work in that setting, I think there were a number of very clear and valid reasons for why that's the case. One is, I think, a historic misperception that the issues of antibiotic overuse and complications of antibiotic use are not a problem in critical access hospitals. And I think I've shown you some data to suggest, and there is certainly other data that suggests that that's definitely not the case. So that is indeed a misperception. One of the big barriers, of course, is the limited access to infectious disease clinicians. So almost no critical access hospitals have even remote access to an ID clinician. And we know in most other hospitals, it's historically been an infectious disease specialist who has really been a champion for and has helped lead the antibiotic stewardship effort. And so the fact that they don't have those staff members, those ID champions, I think has also been a major contributing factor as to why critical access hospitals don't have stewardship programs. And I think it's also a little bit of a reflection of our guidance. If you look at some of the guidance for antibiotic stewardship programs, they tell you that you need to have a team that's led by an ID clinician and a pharmacist. And most critical access hospitals simply don't have that infrastructure. So they said, well, this is obviously not something for us because we don't have the staff members that are required in order to do antibiotic stewardship. So what we have done is, recognizing this implementation gap, we, though, looked at the NHSN survey and found that there were several hundred critical access hospitals that did report implementing all 7 of the CDC core elements. And so what we set out to do was to try and have some direct discussions with some of those hospitals to try and understand how these critical access hospitals were successfully implementing antibiotic stewardship programs. And the goal was really to develop some guidance for how to implement antibiotic stewardship programs in critical access hospitals where the suggestions came from staff members at critical access hospitals. We did this in collaboration with the Federal Office of Rural Health Policy, the American Hospital Association, and the Pew Charitable Trust. So Pew helped us convene a meeting of experts, staff members working in critical access hospitals. We had input from staff members in critical access hospitals in all the states shown in green. So you can see we really did have a broad geographic representation of staff members in critical access hospitals. And apologies to any of you who are joining us from Alaska. Alaska is not reflected on the map. We did have someone who traveled all the way from Homer, Alaska, to join us in Atlanta to help us develop this document that you see here, the implementation of antibiotic stewardship core elements at small and critical access hospitals. So this is a document that focuses exclusively on the implementation of antibiotic stewardship programs at these smaller and in particular critical access hospitals. I'll just touch on a couple of the things that the critical access hospital experts told us about ways that you might do stewardship a little bit differently in a critical access hospital, or some of the things that they had been able to take advantage of. And one was the fact that bedside nurses really need to play a key role in antibiotic stewardship in critical access hospitals. They pointed out that in most critical access hospitals, the only medical staff that are present at the hospital every day at all times are the nurses. And so they are the ones who are really very well positioned to help with some of these stewardship efforts. And in fact, in recognition of this kind of critical need to bring nurses into our stewardship efforts, not just in critical access hospitals, but in all acute care hospitals, we at CDC have been working with the American Nurses Association to try and better define the roles of bedside nurses in antibiotic stewardship. And there's a white paper that we recently released with them, and that's linked here. Staff at our critical access hospitals also told us that the really strong relationships between staff members oftentimes makes these types of performance improvement efforts easier to implement and more successful. They told us, look, once we decide to do this, we're very likely to succeed because there were only a handful of us who work here. We're all invested. We know each other. We work well together. We can get these types of things done. Many of the critical access hospitals told us that, in some of these places, there's a really, really limited prescribing staff. In some cases, there may only be 1, 2, or 3 providers who write almost all of the prescriptions. And so they said, look, it's really easy for us to provide one-on-one education and feedback. There's only 3 providers, so we can really let them know, look, here are your rates of prescribing of antibiotics. And so that's something that may not be feasible in a larger hospital, but is very doable in a critical access hospital. And finally, they said that one of the keys to emphasize for critical access hospitals is that they need to embed stewardship into all of the other things that they're working on. So if they're working on Clostridium difficile, make sure stewardship is a part of that, and combine that with their work on sepsis. So they really said, for us, our quality improvement efforts need to be really multifaceted and encompass all of the things that we need to do. There are now ways that we are working with the Federal Office of Rural Health Policy to try and incentivize the implementation of stewardship programs in critical access hospitals. The Federal Office of Rural Health Policy runs a grant program for critical access hospitals. It's called the Flex Grant Program. And in order to qualify for those monies from the Flex Grant, the critical access hospitals must participate in a quality improvement program called the Medicare Beneficiary Quality Improvement Program. And so about 99% of critical access hospitals participate in this MB-QIP program in order to access those Flex Grant funds. And because of the partnership and the new availability of a specific guidance document for implementing stewardship programs in critical access hospitals, the Federal Office of Rural Health Policy has actually added implementation of the CDC core element as a required component of this Medicare Beneficiary Quality Improvement Program, with implementation starting this year in 2018. So this is, really a powerful incentive. In a sense, it's almost a requirement for a critical access hospital who wants to access these grant funds to take the steps to implement an antibiotic stewardship program. And we are working closely with the Federal Office of Rural Health Policy and with a number of different groups, especially in our state health department, to really do all we can to support these critical access hospitals, give them the tools that they need in order to implement stewardship programs. I'll say one other word about implementation. It's not on the slides, but I did want to mention, many of you are familiar with the playbook that CDC developed in collaboration with the National Quality Partnership. That is a playbook which is intended to help hospitals implement the CDC core elements. It contains a number of very specific and concrete suggestions for how you might implement the core elements. I think many of those suggestions are applicable in hospitals of any size. And the National Quality Partnership is working on a implementation playbook for long-term care facilities for nursing homes. As many of you know, there is a new requirement for nursing homes to have antibiotic stewardship programs as a part of the conditions of participation. And so the National Quality Partnership is working on this playbook for core elements in nursing homes to try and support nursing homes in their efforts to implement stewardship programs. And they expect to release that nursing home playbook in June of 2018. I want to shift gears now and talk a little bit about our efforts to measure antibiotic use. So we think that it's important to measure the implementation of stewardship programs. That's a key infrastructure for improving stewardship. And it's, of course, just as important to actually measure antibiotic use. Like, the ultimate goal is that we have the infrastructure in place in order to help us improve antibiotic use. Most of you, I hope, know that we do have a new part, relatively new, launched in 2012, part of NHSN, called the Antibiotic Use Option, that allows hospitals to capture and report and analyze antibiotic use data. And what this antibiotic use option does, this is a fully electronic module. It captures electronic data on antibiotics that are administered, along with your admission, discharge, and transfer data, which allows us to calculate rates of antibiotic use. And that allows you, of course, to use your own data to monitor your antibiotic use, to look at your use in different units, to compare how your use is over time. It can allow us to aggregate our antibiotic use information within a healthcare system, within a state, within a region, and also nationally. And most importantly, what we were told when we set about to develop an antibiotic use reporting option within NHSN is that what the stewardship community told us is what they really wanted was the ability to do benchmarking of antibiotic use. They wanted us to focus our efforts on developing a benchmark measure for antibiotic use. We have seen enrollment in the antibiotic use option grow significantly, particularly over the last couple of years. And so, those of you who are familiar with the history of this option know that the enrollment was very slow when we launched, but over the last couple of years, enrollment has really begun to grow, and that's quite encouraging. This data is as of December 1st. We had 548 facilities that had reported at least 1 month of data, and most of those facilities were reporting in 2017. And I just a few minutes ago saw the updated number that as of December 31st, so the start of 2018, we were now up to just over 600 hospitals that had reported at least 1 month of data. So it's really encouraging to see this enrollment beginning to grow. The groups, the hospitals that are reporting are fairly diverse. We have reporters from 46 states, and that's now up to 48 states. We have people reporting in from 81 different location types throughout their hospitals. And you can see we do have a fair mix. We have a fair number of smaller hospitals. We do have more of the larger hospitals. We do have some teaching hospitals, non-teaching hospitals. So we do have, I think, a fairly nice variety of different hospital types that are reporting data into NHSN. This is just a map showing the percentage of facilities in each state that are reporting data into the antibiotic use option. Just to give you a sense of the geographic spread, you can see that there are some states where we have a very high reporting rate. So, for example, Utah, more than half of all facilities are reporting data into the antibiotic use option, whereas in most states that percentage is quite a bit lower. But it's certainly been encouraging to see that this percent where several years ago there were a lot of zeros on this map, there are very, very few zeros on this map now. So that's certainly encouraging to see. Well, as I mentioned, a focus of our efforts with the antibiotic use option have been on developing a risk-adjusted benchmark for antibiotic use, and we have developed such a measure called the Standardized Antibiotic Administration Ratio. This is a ratio that expresses observed antibiotic use to predicted use, and the way we calculate the predicted use is to do some risk-adjusted modeling using facility-level characteristics. So we can take a look at your hospital, and based on how many ICU beds you have, how large your hospital is overall, whether or not you're a teaching hospital, we put those factors into a model, and we predict what your antibiotic use would be based on all of the facilities that are reporting data into the antibiotic use option. What we tried to do with this measure is the goal was to try to develop something that wouldn't just be kind of a bureaucratic measure of antibiotic use, but a measure that would really be useful for stewardship programs to try and direct their improvement efforts and assess their improvement efforts. And so what the stewardship programs told us was that rather than having kind of one large category, they would much rather see a number of different smaller categories. And so you can see that we have a variety of different SAR ratios. We have one for broad spectrum agents that are predominantly used for hospital onset or multi-drug resistant bacteria. So agents like piperacillin tazobactam and carbapenems are in that group. We have another category which is primarily agents used for community-acquired infections, so third-generation cephalosporins and quinolones. We have a category of anti-MRSA agents, a category of agents that are predominantly used for surgical site infection prophylaxis. We do have an aggregate category of all of the antibacterial agents, so you can lump them all together. And we separate these categories out. So we calculate different ratios for intensive care units and wards because we know use is so very different in those types of locations. And of course, we have different ratios for pediatric and adult settings. Just to give you a sense of what this data looks like, this is one example. This are the standardized antimicrobial administration ratio distributions for adult medical, medical surgical, and surgical intensive care units. So these are general ICUs. And you can see there's quite a bit of variation. So in each of these categories, there's roughly a twofold variation between the 75th and 95th percentile of reporting, and that's even more dramatic when you look at the whiskers, the 5th and the 95th percentiles. So what this suggests is that there is quite a bit of variation in how the units in these hospitals are using antibiotics. And so anytime we see that degree of variation, it certainly suggests that there may be opportunities for improvement, trying to understand what are the factors that are associated with the lower use versus the higher use. This is just a graph showing where the SAR values were in 2015 compared to 2016. You can see there hasn't been that much change over these years. Again, these are relatively small numbers, 138 locations reporting in 2015, 275 locations in 2016. So hopefully, as these numbers grow, we will get more information that will be even more useful. But you can see that, in some of these categories, there has been a little bit of more of a spread as the numbers have gotten larger. But overall, the median values are not much different between the 2 years. There are a number of questions that we know we need to answer about this standardized antimicrobial administration ratio. It's a new measure for us, and so we have a number of questions that we need to answer about it. The most important question in my mind is whether or not the measure helps anyone. Is this a useful measure in helping point to locations and or agents where there are meaningful opportunities to improve antibiotic use? That's a primary goal of the ratio, and we don't yet know if that's the case. We also wonder about how well the risk adjustment works for the SAR as we have it. As I mentioned, we don't have patient-level information, so I can't risk adjust this SAR value for how many oncology patients you had in your hospital last year, for example. And the question has arisen, how would the risk adjustment change if we were able to add more information? And finally, if you are able to use the SAR to find opportunities to improve use, and you execute improvements, do the SAR values change as you take steps to improve antibiotic use? So these are some of, I think, the really important questions that we're trying to answer about the SAR. We've got a little bit of anecdotal information that I'll share with you from some kind of small surveys that we've done and feedback that people have given us. One hospital did tell us that they have found the SAR to be useful in pointing them both to agents and locations where they have gone to prioritize further investigation. And this hospital said, for us in particular, knowing that our use is higher, rather than just thinking that our use is higher, has been really helpful when we talk to providers. And the example that she gave us was, in their MICU, for a long time they have said, hey, our MICU, we use way more antibiotics than we think we should. And the MICU said, well, we think we're pretty much in line with other MICUs. And in fact, when they got their SAR values, what they found is that their MICU had a SAR value of over 2. So they were using twice as much antibiotics as other comparable MICUs. And when they took that hard number to the MICU, they said it really helped them engage the MICU in an effort to try and improve some of that. So that was certainly encouraging to hear. Again, experience just from one hospital. And this slide is not, there we go. This is data that has been shared with us by Eddie Steinium at Intermountain Healthcare. And they've been using the SAR at a system level. And so what they have found is that the SAR does provide some insights that help them dig deeper into antibiotic use. So this arrow points to a hospital that had an overall SAR of right around 1. So, at face value, there didn't seem to be much opportunity to improve use because the overall SAR value was about 1. But what Eddie says is, for each of these values, he expands that to look at the SAR values for the individual agents. So on the lower panel of this graph, what you can see are the SAR values for several of the different SAR agent categories. And this one over here on the right is agents that are primarily used for surgical prophylaxis. And you can see that SAR is extremely high. I think it was 4 or 5. And so when he dug into that further, he did find that there were a lot of opportunities to improve the way that this hospital was using agents for surgical prophylaxis. There were some really excessive durations of surgical prophylaxis that were reflected in this SAR. So again, an example of being able to use this SAR value to target your stewardship explorations. And finally, this is data that's presented in abstract form, but now it's been published by Daniel Lavorsi and colleagues at the VA hospital in Indiana. And they used the SAR to monitor the effectiveness of their stewardship program. So they started a stewardship program in 2013, and they monitored the SAR values over time. And I'm sorry some of the axis labels are cut off here, but basically what they were looking to do was decrease the use of their broad spectrum hospital onset agents, things like carbapenem and piperacillin tazobactam, and they were looking to reduce that use. They were focused on reducing the use of MRSA agents. And then what they were looking to do was to shift people to narrower spectrum agents where the narrower spectrum agents would have been more appropriate. So for example, one of their big interventions was to shift people away from piperacillin tazobactam and carbapenem and towards cefotaxime for community onset and community type infections. And so what you see here is that the SAR value was able to capture the effectiveness of what they did. So the broad spectrum agents, the BSAs, went down in both wards and intensive care units. Anti-MRSA agents went down. And over here, the agents, this is what's cut off, is these are agents used to treat community onset infections. The use of those agents went up. And that's exactly kind of what they had hoped to do. And what was interesting is that they said, if we had only looked at overall antibiotic use, that didn't change very much. It went down, but not very much. And it really was hiding the very, very effective intervention that we were able to do. So just another example of how we might be able to use the SAR data. Well, what about risk adjustment? We've been working with Kaiser of Southern California. The Kaiser system has the luxury of having all of the patient-level data in a central database. And Kaiser of Southern California is also reporting data into the NHSN Antibiotic Use Option. And so they were able to compare the benchmark values using only facility-level risk adjustment, like what we do in NHSN, to much more granular risk adjustment using a number of different patient-level characteristics. Made a couple of really interesting findings. First of all, they found that there were really two patient-level factors. Diagnosis-related group codes, those DRG codes that are used by so many hospitals through their as part of the billing system, and the infectious disease diagnostic codes that were determined after discharge. And they said, if you only risk adjust on those two models, you get almost identical results as if you risk adjust using all of these specific factors like white blood cell counts, creatinine, outpatient antibiotics, Charleston comorbidity scores. What they have found is that you probably only need the DRG codes and the infectious disease diagnosis to get really, really good patient-level risk adjustment. What they also found that was quite encouraging was that there was quite a bit of agreement between the facility-level antibiotic use ratios that we can generate out of NHSN with the patient-level risk adjustment that they were able to do through their Kaiser database. You can see that for each of these different SAR categories, there was anywhere between a 72 and a 92% agreement between these two values. So I think that is very encouraging and definitely suggests that the facility level risk adjustment is not perfect, but it certainly does give you quite a bit of risk adjustment that you would see if you had patient level factors. So we continue to work on exploring and refining the risk adjustment of the SAR, and we continue to work on assessing the application of the SAR for stewardship. And in fact, to this second point, the Duke Antimicrobial Stewardship Outreach Network is underway. They are currently working on a project where they are going to enroll a group of hospitals in the NHSN Antibiotic Use Option. They're going to be implementing or expanding stewardship programs or elements at these hospitals, and they're going to assess the impact on the SAR measure. So it'll be a really nice study to determine if we expand stewardship implementation, will the SAR values move in directions that we think they're going to. We are also trying to use the antibiotic use option data to try and answer important questions about antibiotic use. You know, one of the big changes and drivers of antibiotic use in the last several years was the implementation of the CMS sepsis measure, the SEP1 measure. And, you know, when this measure was implemented in October of 2015, there were a lot of concerns that were raised about potential increases in broad spectrum and anti-MRSA antibiotics. And so what we did is we said, well, we don't have a lot of antibiotic use data at this time, but let's look at what we have and see if we can get any indication of whether or not we're broadly seeing these types of increases in the use of broad spectrum and anti-MRSA antibiotics. And one nice thing that we had in the antibiotic use option is that at that time, in 2016, we had a mix of about half and half. About half our reporting facilities were VA hospitals that were not required to implement this sepsis measure, and the other half were hospitals that were required to implement the measure. And so this is data that we presented recently at the IB Week meeting, and the take-home point that we found was that at least in this limited data set that we had, we did not see a significant increase in the use of broad-spectrum antibiotics or anti-MRSA agents when you compared VA and non-VA hospitals. So there were no statistically significant increases in the use of these agents in the pre- and post-SEP1 era. And again, this is a very small sample size, but for us, this was a nice illustration of the power of the antibiotic use option to do some of these analyses and answer some of these questions about antibiotic use in real time. So measurement remains a key focus for us here at CDC. Excuse me, for all of our hospital stewardship work. You know, it's always said that what gets measured gets done, and measurement, you know, has always been a challenge in antibiotic stewardship. But I think we're making some real progress, both on measurement of program implementation, on antibiotic use, and we're also taking steps towards trying to measure appropriate antibiotic use. And I didn't have time to talk about that today. And certainly, you know, I would value input from you. We're always looking for the types of things that we need to be working on. So we value any input that any of you have on what we can do to try to advance measurement in antibiotic stewardship. So with that, I'm going to turn this back over to Marnie for a few minutes of question and answer. I think we have about 5 minutes for some Q&A. And so let me turn this back over to you. Marnie?
Terrific. Thank you, Arjun, so much for going through your data and your approaches to the data and how to try to utilize them. I just remind the participants, submit any of your questions now via the chat box. We did have some submitted, so I'm going to go right to them. So earlier in the presentation, Arjun, you described the NHSN survey, and then you also described the comparative Vizient survey. There was a question around, did Vizient validate any of the other data in the NHSN annual survey, particularly the microbiology practices portion?
I don't believe they did. It was just validation of the stewardship plan.
Okay, I have a question with that. Who does that survey go to?
The visitor survey?
No, the NHSN.
The NHSN survey goes to whoever the facility administrator is for NHSN. So every facility that is enrolled in NHSN has to designate a facility site administrator. And so that person kind of receives the official emails from NHSN.
Okay. So although you don't really have the data of who historically filled it out.
We don't know who that person is.
Right, but you're seeking to obtain that data going forward.
We are, yeah. So we will be specifically asking the stewardship question. That portion will say, did someone from the stewardship team participate in filling out the stewardship questions? Correct.
And that's ideally, you'd want them engaged.
Absolutely, yeah. We would love for that number to be 100%.
Okay. And then another question was regarding the critical access hospitals can apply for a grant through their state, I believe the FLEX programs.
Yeah, so it's the FLEX grant program. And so, if you are at a critical access hospital, you probably already know about the FLEX program because 99% of critical access hospitals are already enrolled in the FLEX program. But there's a FLEX administrator in every state. So if you want more information about the FLEX program, you should be able to find if you just search for your FLEX administrator. And if you can't, let me know. I would certainly be happy to connect you with the folks who can put you in touch with your FLEX administrator for your state.
Are there any similar programs for long-term care facilities or the small?
Not that I know of.
Okay. That was one of the questions, not at the present time. Switching to the antibiotic use option survey, which is a different survey, correct?
Yeah, that's right.
Okay.
It's actually, it's an ongoing system. So it's not, it's a reporting system that people are continuously reporting data into.
Okay. So really, you would really like to see more people submitting information to that, so you can.
There are some, there's some information technology barriers that have to be surmounted. It's an electronic system, and so you have to work with. Most people do it through their pharmacy vendor system, and so they have to configure your data to be submitted electronically into NHSN. So there are some technical barriers that have to be overcome. But we definitely are seeing more and more hospitals successfully overcoming those barriers and submitting data. And more companies are now adding reporting into the antibiotic use option as a feature of their system. So a lot of the EHR companies, the pharmacy vendor companies now will allow you to report data into NHSN.
Okay. Yeah, I was just noticing on the map that you showed, obviously, Center for Infectious Disease Research and Policy is located in the state of Minnesota, and right now we're, as of 2017, we were at 1%. So, yeah, just how states could come more online at submitting their data.
Yeah. So, we're seeing more enrollment every day, and there's lots of information on our website about the steps you can take to get your hospital up and running.
Is Utah so high because did you do a pilot study or collaborate with the Intermountain?
Utah is really high because most of the hospitals in Utah are part of the Intermountain healthcare system.
Right.
And Intermountain was, yes, they were one of our pilot systems.
Okay, great. Yeah. A question from one of the participants pertains to the surgical prophylaxis category.
Yeah.
Their impression is that operating rooms are excluded from the antibiotic use mapping. So then with the surgical prophylaxis drug category, is that a misleading number?
Well, so that category is challenging for a few reasons. And actually, the fact that the ORs are excluded, we can capture data from the ORs and the post-recovery areas, and some places report that. But what the stewardship folks told us is, my opportunity to intervene on surgical prophylaxis really comes for those patients who, they just get kept on that cefazolin prophylaxis after they get admitted to the floor after their surgical procedure. So they're a little less concerned about what's being given in pre-op and in the OR, but they really want to know, well, how much of this use might represent, getting 2, 3, 4, 5 days of therapy after the surgery while they're on the ward. And so that's why, having it be reported from the hospital location seems to make sense. And so it does allow people to capture that.
Okay, that's excellent. I encourage all the participants today that were listening to the webinar that they would be able to contact you or someone within your team to provide feedback on how to best utilize, design these surveys and utilize the data. One final request is from someone that would like information for critical access hospitals, facilities in the state of Florida and Georgia. So that might be something that could be followed up between the two of you.
If you can't reach your flex coordinators in those states, do let me know. We would be happy to connect you.
Okay, great. Well, we're out of time, Arjun, so we're going to have to close. Thank you so much for all of your insights and for reviewing the most recent data beyond the publication we were highlighting. I think I'll be excited to see what the data, what your data from 2017 looks like.
Yeah, we are too.
Yeah. So that concludes our Antimicrobial Stewardship Project Journal Club webinar today, which was recorded and will be available on our website. And I just want to thank Dr. Srinivasan for your time and also thank our participants.
Thank you. Thanks, everyone.
Everyone have a great weekend.